Welcome to Heart Nurses, brought to you by the Preventive Cardiovascular Nurses Association. PCNA's mission is to promote nurses as leaders in cardiovascular disease prevention and management.
Today, we're in conversation with nurse practitioner Lisa Maher. Lisa, why don't you go ahead and introduce yourself?
Hi, my name is Lisa Maher. I'm a nurse practitioner for the Unitypoint Health Allen Hospital Cardiovascular Center that's located in Waterloo, Iowa. I've been in practice there almost 14 years now as a nurse practitioner. I focus on treating patients with any general cardiac disorder. So that can be anything from chest pain to coronary disease to AFib to heart failure. And then I also specialize in sleep apnea and run our sleep apnea clinic, in which I see patients suffering from any sleep disorder, specifically obstructive sleep apnea or complex sleep apnea. I see them about 1 to 2 days a week.
So it sounds like we could have a number of different conversations based on your expertise, and we are so glad that you've decided to join us today. I think our focus today should be more on AFib, and we will weave in some of those other things. And so, Lisa, if you could tell us initially, can you describe the relationship between sleep apnea and AFib?
Yeah. So this is something that not a lot of times is brought into the forefront when we talk about AFib. Sleep apnea is unfortunately something that a lot of times will get pushed to the back of the table or the back of the discussion because we're more worried at the time about treating the AFib, because usually that's what patients feel the most symptomatic with, is their symptoms related to AFib. So the relationship when the atria are sensing that there is some type of stress within the heart, when we look at things, a lot of times we're talking about rate control and changing the rhythm, where as sometimes we miss the underlying condition, the cause of the AFib. With the correlation between AFib and sleep apnea, we're looking that the heart can get stressed at night, especially when it's not receiving appropriate oxygen. And when it's not receiving appropriate oxygen at night, one of the ways the body responds is that the heart can freak out and we can see an abnormal rhythm. So a lot of times that's when we see AFib initially occurring at night. So in our patients with AFib that maybe they're not symptomatic, or maybe it's a paroxysmal AFib where they're in and out of rhythm, a lot of times when we have them wear a monitor for 24 or 48 hours or 2 weeks, what we see is they're having more incidents at night. And when they're having more incidents at night of that AFib, then we should automatically look to rule out any underlying sleep apnea. So at that point, we'd want to talk about the importance of getting a sleep study and just seeing if there is any oxygen desaturation or if there's truly the underlying condition of sleep apnea. Once we have that diagnosis, it is so important to treat. When we talk to general cardiology and then we talk to EP, once they reach that electrophysiology standpoint and we're specifically looking at treating EP, one of the things they always fall back onto is treatment of the AFib, because then we're looking at the long-term success of medication therapy in patients who have their sleep apnea treated and use certain type of medications such as antiarrhythmics, or go for procedures such as ablations or cardioversions, have better success rates if their sleep apnea is treated appropriately.
Thank you very much for including that idea of sleep apnea as we're in the clinical setting and working with patients. So as we're talking about that trajectory from diagnosis through treatment, if you wouldn't mind spending a little bit of time talking about how important anticoagulation is in that whole process.
Yeah, this is something that I talk with my patients when they have AFib extensively. And a lot of times we're going to want to look at, I talk about AFib itself is not life-threatening. It doesn't hurt you, it doesn't hurt the heart. But with that, there's always that hangover of stroke, the risk of stroke, which we know can be fatal, or it can resolve itself. But most of the time we don't know how people are going to respond to a stroke until they have that, and then we're stuck dealing with those consequences. So when it comes to treatment in AFib and anticoagulation, we look at a score, and we use a score called the CHADS-VASc score. That helps us to risk stratify any underlying risk that would increase their risk for stroke. When we look at a CHADS-VASc score, We look at their underlying, so CHADS-VASc stands for congestive heart failure, hypertension, their age, whether they're diabetic, the sex, so male or female, and then whether they have any underlying cardiovascular or vascular component to that. If they have any one of those conditions, we rate this in the scale. The higher or the more number of conditions, or the higher the points, the greater increase their risk for stroke is, so the greater likelihood we would start them on anticoagulation. When we start anticoagulation too, one thing we always look at is also their bleeding risk, because if somebody just had a major GI bleed or has an underlying condition that predisposes them to that, it might not always be the safest. The other thing I always look at when starting anticoagulation is going to be a patient's age. So with that, sometimes you have these 90-plus-year-old patients. Sometimes they are completely independent at home and they're not a fall risk, but sometimes you have those patients too, fall risk. That takes into account whether you would want to consider anticoagulation or not with them. When talking about anticoagulation too, something we always look at is going to be the guidelines. So when talking about the standard warfarin or Coumadin versus the NOACs or DOACs that are out there, one thing I stress when I'm talking to patients is the risk of bleeding versus the risk of efficacy with the medications. One reason in particular my patients tend to like a NOAC or DOAC would be the ease of taking it. It would be once daily or twice daily, depending on which medication. And with that, once they take it within a certain period of time, usually up to 6 hours, they are going to be therapeutic, meaning their risk for stroke is cut down. When we look at warfarin or Coumadin, we sometimes could take days to get that regulated. We could take weeks to get that regulated depending on the dosage and how their INR level responds. So that deals with lab work and the routine lab work. In two specific patient populations, we would not want to start a NOAC or a DOAC. Those would be the patients with a mechanical valve. So anytime there is any mechanical valve, the NOAC or DOAC, the new anticoagulants, are not indicated for those patients for treatment, so they would have to stay on Coumadin or warfarin. And then the other would be with mitral stenosis patients. So if you have a new AFib patient, you don't know their underlying valve history, and you would get an echo or an ultrasound of the heart, you would want to look to see if there is any underlying evidence of mitral stenosis. If there is moderate or severe mitral stenosis, Coumadin or warfarin would be indicated, as would a NOAC or DOAC would not be indicated for those patients.
Great. I had a question about the anticoagulants themselves. I know that some come with a reversal agent,
Yes.
Others do not, so I suspect that's a consideration in practice as well. And I also was thinking about patients who are slated for, let's say, a dental procedure. So could you talk just a little bit about what being on an anticoagulant of any kind has to do with those two things?
Yeah, you bet. So when we're talking about anticoagulation and reversing, rarely do we actually fully reverse the anticoagulant or give them a medication that would either get that completely out of their system or bring their level down, unless it was a serious event, like a car accident. When we're talking about stopping it for an elective procedure, usually there are guidelines set up as far as how long that can stay in the system. And sometimes it is surgeon dependent, and sometimes it depends on the patient's underlying condition too, in which they were started for the anticoagulation. With warfarin or Coumadin, it does take longer to get out of the system. So usually they are off that medication longer than standard NOAC or DOAC would be 24 to 48 hours depending on the procedure.
Great. So there are a lot of considerations when it comes to treating AFib and what treatment is best for each patient.
Yes, correct.
We're here with Lisa Maher, and we'll be back in just a moment to talk more about AFib.
For more education, resources, and tools for your clinical practice, visit PCNA.net. You'll find CE courses, patient handouts, and more, all free to access. Visit PCNA.net.
We're back with Lisa Maher, and we're talking about AFib and some of the considerations for clinical practice. So we've spoken already about identification and treatments, and I have a question for you about rate controlling medications. Can you talk a little bit about how beta blockers, calcium channel blockers, and other medications are used, and anything that as a clinician we might want to watch out for?
You bet. When we're talking about AFib, when we are talking about controlling the heart rate, what we will do is we'll look at certain classes of medications that are helpful to control the heart rate and obviously that are safe for the patient. We look at two classes most often. Those are going to be your beta blockers and your calcium channel blockers, purely for rate control rather than rhythm control. So sometimes people get confused when we talk about all of this. So rate control means that we're purely just controlling the heart rate. Usually we want to get that heart rate less than 100 beats per minute so that the patient is not so symptomatic. A lot of the times when you hear patients symptomatic with AFib, it's purely because the heart rate takes off and races. So if we can control that heart rate, we can keep their symptoms under better control, and that allows us time to figure out what we're going to do or how we're going to treat the medication. When we're talking more about rhythm control, we're talking about a group of medication called antiarrhythmics. Those are specifically started to change the rhythm from AFib to a normal sinus rhythm. Those are medications that are not always started in an outpatient setting. So those are something that I advise you talk with your general cardiologist, and usually at that point it referred on to even an electrophysiologist at that point to start these medications. Again, some need to be monitored very closely, and the patient needs to be admitted to the hospital in order to watch, because even though these medications are safe, if started as an outpatient, what we want to monitor for is that they wouldn't have an adverse effect and have that medication be pro-arrhythmic or actually cause them a life-threatening rhythm.
So we've talked a little bit about medications and how to control AFib using anticoagulants, how to do rate and rhythm kinds of control, but sometimes that doesn't quite get the job done. So I'm hoping you could spend a few minutes talking to us about the potential for pacemaker therapy with AFib and how that fits into the complement of treatment that we might have.
Yeah. So with AFib, a lot of times people automatically think of AFib and they think of any rhythm and they automatically think of a pacemaker. That's not always the case when we talk about AFib. Usually, purely because of the nature of AFib and the way it affects the SA node, over time, naturally the heart rate can slow down, and that's when we would use pacemaker. So sometimes the confusion is that if patients get a pacemaker, it is going to cure or fix their AFib, when it is not going to do that. A pacemaker is purely used to help with a slow heart rate, to improve a slow heart rate. And at that point, if the patient is still in AFib and a lot of times having a fast heart rate, we can add those medications such as the beta blockers, such as the calcium channel blockers, to bring down their heart rate without worrying that we're going to bottom or cause the patient to get dizzy and pass out. So pacemaker is used sometimes in conjunction where we want to get the heart rate slow, but we can't get it too slow, but we still need medication to help.
So it sounds like in all of these different types of therapies, using shared decision-making is a very important aspect of this, because different medications, different treatments are going to affect different patients in ways that maybe are unexpected, or maybe we know what to expect and maybe isn't going to fit into their quality of life. Are there any key takeaways for discussions with patients about these particular methods for treatment that you use in your clinical practice that we could apply in ours?
I think it's just an honest discussion with each patient that comes in, because each patient is not going to have the same circumstances surrounding the AFib or in their other health conditions or their social aspects of life. So I think it's just having an honest conversation about AFib and saying, look, these are our options. This is one option. Here are the risks or benefits associated with this. Here's another option, and here are the risks and benefits associated with this. Let's figure out what will work best for you. So again, a lot of times there is a stepwise approach to treating AFib, but you have to look at the patient and you have to involve and use that shared decision making, not only with the patient, but also family members or caregivers who are also involved in their care. Because AFib is usually not something, it's just a one-time and done thing. AFib is more of a nuisance and it continues to come back. It all depends, too, on how symptomatic the patient is. If the patient is really symptomatic, we're going to want to do things quicker and more effectively to help them feel better. If they're not as symptomatic, we definitely have more time as long as they're anticoagulated.
Great information. I also was hoping you could touch on AFib and cryptogenic stroke because of that interconnectedness there.
Yeah. This is also another really interesting topic that I do think gets missed. So if a patient comes in with a TIA or a stroke, first thing we want to do is try to find a cause. We want to obviously treat the symptoms too, but we like to look for an underlying cause. Usually that will involve neurology workup. If neurology workup is okay, if the imaging of the head, so usually a CAT scan or MRI of the head and neck, if there is no underlying clot or any vascular disease as far as a carotid disease, what we want to do then is look from a cardiac standpoint or a heart standpoint. Usually at that time that will involve either consult while in the hospital to cardiology or an outpatient consult if the patient is well enough to go home. At that point, we're going to want to look at an ultrasound or an echo to ensure that there is no underlying PFO or hole or abnormal communication between the right and left sides of the heart. If there is a PFO, we want to treat or look at treating that to see if that is the cause. If that is negative, the next thing we want to do is work on some type of monitoring. So what people a lot of times don't understand is with AFib, sometimes AFib comes and goes so briefly, it's there long enough to cause the stroke, but by the time the patient seeks attention, they're back in a regular rhythm. So ideally, we would do some type of monitoring. Usually, we will start with a 24 or 48-hour monitor just because that's very easy to hook up the patient and send them home. If that comes back negative, meaning that the patient has stayed in sinus or there is no underlying atrial fibrillation, at that point, we want to do longer monitoring. Now, this is insurance dependent, whether we would have to proceed with a 30-day monitor or whether we would look at what's called a loop recorder, an implantable device to monitor for any underlying rhythm. A loop recorder can be left in for up to 3 years, and it's a very helpful tool that if the patient is not symptomatic with AFib, we can track and find AFib. So cryptogenic stroke basically means that there is not a cause found. So at that point, we presume it's underlying AFib as the cause. We just have to catch it, basically.
So when you use the loop recorder, how often is your office looking at that information? Are there trigger points that are causing your team to take notice?
Yes. So with a loop recorder, initially after it's put in, we always like at least a 7 to 10 day check. And that's to check the actual insertion site to make sure it's healed okay, but then also to make sure it's reading appropriately and capturing appropriately. Beyond that, the patient has a home monitor that they go home with. The home monitor consists of the actual monitoring piece of it, but it also has a little trigger button. So if they would ever feel something, or if they would start to exhibit symptoms of a stroke, spouse or significant other or caregiver or family, if they're with it, could also press the button for them and we could trigger that event. If an event is triggered, that immediately uploads to my office system. And at that point, we can see, is there a correlation? Is it truly an underlying rhythm? Or is it something that maybe the patient felt like the heart was racing or going fast, and it could have been an underlying anxiety or something else? Beyond that, if they don't trigger any events, it is checked at least monthly. And then usually that is a remote check unless the patient prefers to come into the office. But the nice things about these loop recorders is they're with the patient, they're very small. you don't have a large scar, and they go anywhere. So if you have a patient that travels, even overseas, or travels to see grandkids or something that way, the device continues to monitor and uploads that information. They can always take their special remote with them, and it can trigger an event or trigger an event that we would see from anywhere. So that's the really nice thing about it.
Well, it sounds like there are plenty of opportunities for learning more about AFib and how to apply the great information that you've shared with us today in practice. Is there anything else that I have neglected to ask that you would like to share with our audience?
No, you've done a great job asking. I think it's important for people to pay attention, and if they feel something different, whether that be a sensation in their heart, a palpitation, a pounding sensation, a fast heartbeat, to just talk to your doctor, your provider about it, because if we can catch it and we can prevent a stroke, that's definitely what we want.
Most definitely. Well, we've been in conversation with Lisa Maher, and our audience cannot thank you enough for sharing such great information about AFib in this podcast. I'm your host, Geraldine Warfield, and we will see you next time.
Thank you for listening to Heart Nurses. We invite you to visit PCNA.net for clinical resources, continuing education, and much more.